Yeah, I think really where I would like to see the field moving is designing clinical trials that are going to use MRD as to change treatment decision making. And so I mentioned maintenance therapy, where I think that's really one of the areas that we can focus on the easiest, where we have lots of patients who are on maintenance single agent or possibly more than that, but single agent maintenance therapy, and we have a potential to really de-escalate therapy in those patients who are MRD negative. But there's also the flip side, patients who are post-transplant who frequently get a bone marrow biopsy at day 60 or day 100, those who are MRD positive, that may be an indication that we need to escalate post-transplant therapy, that maybe single agent maintenance therapy is not enough. And there are some trials ongoing that are going to be looking at that to some extent. And then if we move even earlier in treatment, looking at prior to transplant, post-induction therapies, if there are those fortunate patients who are MRD negative at that point, could that allow us to actually bypass transplant in the frontline setting? I think those are three areas where we can really focus on using MRD in terms of helping us make decisions at the bedside.